Ready to go for, you guys want to go?
It's a lot of fun.
Anybody want to go? Tim, you want to join us?
With my family, we'll probably do
Oh,
something else.
you are with your
Yeah.
family? Okay.
We do that.
All right. Or they're going to come, and Brady will probably come.
What? I wasn't listening.
After we're going to go over the top golf after, I don't know if you want to come.
I gotta go home to wife and kids. Yeah, I've been gone all week.
All right, we'll
What,
get a few
4
of
or
us.
5
1,
guys?
2, 3. You guys want to come?
Yeah.
4 of us?
Okay, perfect.
Drew?
But I'm the only dentist in the United States that thinks golf is dumb, so.
Actually,
I'm kind of with you on
golf
that.
is actually
Although top golf
different.
is fun.
Different. I don't like golf.
Have you ever gone?
Yeah, it's just fun. It's
Yeah.
good to do when you're old, right?
It's fun to do it.
Top golf is different than regular golf.
Because it's not just like hole in one, it's
I feel
like,
like I've been gone all week,
It's
so
fun.
I'm headed home today.
Okay.
All right, you ready? All right, so aesthetic planning. So, can't see, the light's not good, but these are some, this is a veneer case.
We'll probably kill the light on the front there.
it dims right there, I think.
Here.
Was there a dimmer?
Yeah.
This one here.
Oh, yeah, oh, that's
Not
that
better.
right there.
Yeah.
Jeez, we've been doing that all along. All right, so, we're gonna talk about aesthetic treatment planning so we can get nice aesthetic outcomes. This is a veneer patient. We'll probably get into more detail with her case. I can't remember. But aesthetics is a branch of philosophy dealing with beauty and taste. And there's a subjective and there's an objective component, right? So what's beautiful to one person is not necessarily beautiful to another person, right? We all experience that with art, for example. You know, the current trends I'm seeing in cosmetic industry that are driven a lot, social media driven, are very, to me, very kind of contrived, kind of artificial and too white, too blocky. It's not my thing, but it is, seems to be a cultural trend that we're seeing. And so, you know, aesthetics kind of can evolve from, you know, time periods too, even in short time periods we're seeing. Sometimes I wonder if anthropologists are going to like look at our skulls and look at, you know, these people went through this phase of doing these weird things to their teeth. And then, you know, we went through a phase of titanium because now I think eventually we're going to be growing teeth. And maybe titanium isn't going to be what we're going to be using. We're going to be growing teeth in a petri dish. And maybe titanium will be a thing of the past. Who knows? Maybe not in our lifetime. But
Osteotomy is gonna be big.
So here's a video about aesthetics.
That's terrible.
Not the aesthetics we're after. Okay. So these are kind of some foundational concepts that we're going to use to kind of build upon through the rest of this discussion. Okay. Again, this is another veneer patient that we treated in the office. We also did some dermal fillers to make the lips fuller. Anyone doing any of that? Lip plumping, Cubiderm, wrestling.
Do you do it?
I do, yeah. I don't do it, I've been doing it for over 10 years. It's not something I market, not something I broadcast, but it seems like I end up doing family and friends and people more than anything. But on patients, you know, like this patient, we did a smile makeover, and, you know, during the discussion with her case, she's like, I don't like my lips. And I'm like, well, we can make them fuller. So I'll go ahead and do that. So basically, tooth position, gingival levels, arrangement, contour, and color. Those are the 5 key components to dental aesthetics. And knowing how to evaluate these 5 areas is really critical regardless of whatever treatment modality that we're using. And let me move forward and I'll explain this. Aesthetic tooth position, okay? Most challenges in treatment planning have to do with aesthetic tooth position. And think about this for a minute. I bet every one of us has a case or models on their desk or somewhere back in their office. It's that case that you're like, What do I do with this? Anyone have a case like that in their desk right now? Sitting on their desk, just staring at them, waiting for like enlightenment to come in. And if you really sit down and look at that, or if you take a case like that where you're stumped and you take it to like a Frank Spear or someone that's really good at doing this, you'll find that most of those challenges come down to a tooth position issue. That's what makes the case challenging. It's because of the tooth position. So if we can solve the tooth position problem, the other things can come into play. So that's why this concept of facially driven treatment planning is so popular, because the tooth, the front teeth, drives the aesthetics of the whole case. Okay? For example, this patient, challenging case, right? What makes this case challenging?
No bone, all sorts of stuff.
Okay? But if I showed you a picture from a side profile, if you looked at the occlusal plane, what you would look at is you would notice that these teeth are way too down and forward in his face. So this, again, is another example of a tooth position problem, okay? If we can start to get the front teeth in the right spot, then we can start to develop the plan. What I will tell you is, part of the plan for this guy, he's got a lot of agenesis and a lot of missing teeth, okay? Look at this defect. You can't even see where that thing ends. It's a horrific defect. But when we decided on the plan, the first part of the plan was orthodontics, and we were able to solve some of it, set him up in a better way by intruding these teeth, leveling the occlusal planes, and ironically this defect went from being this horrific to not as big once this bone and soft tissue got back in the right spot. Okay, there it is. You could put your hand through that thing. Challenging case. This is Bruce, okay, the one we talked about in the last segment. Look at how close this interdental papilla is to the lower incisor. What about this? What do you do about that? A patient walks in your door. What do you offer them?
Crown with acrylic up on the gingival half or something, I have no
What
idea.
do you do?
Maybe refer them for a consult for CT graft, possibly. That's possible.
I wonder if you extruded the tooth incrementally, you could bring that gum tissue down too. It might sacrifice the tooth, but I mean, you could get the gum tissue level closer.
It's a great idea. There's only one problem here. But with that same concept, you could do a segmental osteotomy. I mean, I couldn't, but there's people that could do that. You could bring the whole segment down. Or, you know, this is the kind of question that I have, this is the kind of case where you have dialogue with the patient. Mr. Patient, what is your ultimate goal here? Is your ultimate goal to get like the very most absolute best aesthetic outcome that you can get? Or is it to be as conservative as you can be?
Can you get rid of her high smile line by doing Botox on the upper lip or something so that it won't come up so high? No, seriously.
No.
The process department at the dental school I went to, they stopped doing crown lengthening and maxilla repositioning surgeries and started doing Botox on these cases. And they presented 40 or 50 awesome cases where
The answer
they fixed
is
this
yes,
with
and I've done it many
Okay.
times for gummy smiles. We're going to get into evaluating gummy
Has
smiles.
it worked well in your experience or not?
It works well, but it's a lifelong commitment.
Yeah, every 6 months, right?
Yeah, and then getting it symmetrical, you know, because the levator muscle, like, you know, it's dynamic and it's not going to respond the same way, and every clinician is different, and the dosing, it's a solution, but it's not.
While we're there, I know you have a course that you go to that you prefer for Botox and fillers.
The only one that I'm aware of is called Academy of Dental Facial Aesthetics. It's
Yeah, okay.
Lois
Yeah.
something like
Yeah.
whatever. They have probably the most comprehensive. I've been doing it so long. I was doing it. I wish I would have developed one of those courses because I was doing it before those guys even were around.
With being
But-
there, with being in Arizona, have you noticed are you pretty restricted? I mean, because we are.
With Arizona, was actually at a board hearing, and I realized how political this was. So I had been doing dermal fillers, like I showed you in the lips, for a long time. The way it came about for me was my brother-in-law worked for a company called Medicis. Medicis imported a product called Restylane. You ever heard of Restylane? Restylane came to market before Juvederm did. Juvederm is distributed by Allergan. So he said to me, hey, my company is getting the exclusive US rights to distribution of this dermal filler product called Restylane. It's been in Europe for 7 years. It's coming to the US. It's finally passed FDA approval. There's a plastic surgeon in Manhattan, from Manhattan, that's really well known. He's doing a course on these dermal fillers. Do you want to come? I'm like, yeah, sounds cool. I didn't know if I wanted to do them, but I wanted to learn. So I go to this course and I'm like, you can do that? It's easier than the crap we do, right? So I do this, and then I start doing some family and friends, just lip augmentation, just little lip fillers. And then the rep for the company came in one day because I was training some people. She says, you're really good at this. I've been around the valley and I've seen lots of surgeons. You have a knack for this. Will you do my lips? I'm like, okay, she works with plastic surgeons all day. She wants me to do her lips? I'm a dentist. Okay, sure. So I did her lips, and I did it for a long time. Somehow it got to the president of the company, and they wanted to put a course together, and they wanted mostly someone to teach dental blocks, because their RNs and most of the medical side people didn't know how to really do anesthesia. So they were going to hire me to do dental blocks. Right before my first lecture was scheduled, they squashed it because Juvederm was coming into market. Lips was off-label use. You could use it for lips, but it wasn't FDA approved for that. So they were afraid that if they were promoting off-label use, that FDA could pull the product from them. So they squashed any promotion of it. So my gig went away. But I got introduced to it early on. I think it has its place. Now you can get into trouble if you don't know the anatomy. You get into labial arteries and stuff, and you could have occlusions and big
Well, I
Oh,
mean,
problems.
if you're doing Botox in crow's feet, glabellar area for dentists.
The
then
definition
we're-
is this. It has to fit within the dental, part of the dental treatment plan, okay? So, to me, if I'm doing, I don't want to go down this long tangent with this, but if you're doing, treatment for facial pain, headaches, for muscles, okay? That's typically going to consist of injections in the temporalis, masseter,
So you could kind of,
yeah. So what I say is, you're having headaches. It's documented in the chart that they're having headaches. And if someone's coming in and you're just doing what the med spas do, and you're getting rid of crow's feet and getting rid of this, you're in an area that you could be in trouble with the board in Arizona.
right, okay.
So it's got to be. But most patients, you can make it fit within the scope of headaches, right? Because think about it. If you got a patient that has tensions, do you ever get headaches? Yeah, occasionally. Okay. A patient has a history of headaches. We're going to treat them with Botox. You can't really argue that.
Yeah, I mean,
And while you're in there, you can do the crow's feet, you can do Proceris and Corrugator and those.
okay. I've only been doing this for a month, but
Yeah.
just in hygiene, I've been seeing a lot of those, and I have the intention of doing Botox for
Yeah.
headaches. Is that something that you're seeing a lot of success with?
I find that it's a great modality as synergistically. So you got someone that's just got a lot of hot muscles. I'll use it in conjunction with the splint to kind of turn things off. But I don't advocate it as like this is like a long-term management strategy, because you're going to have to do that every so often, so frequently, and it's expensive, and I don't know that it's something that you want to do for life. But I find it works quite well when you got some of these hot muscles and you want to shut them down with by splint and Botox. I've had it done on myself. I do it to myself because I get a lot of temporalis headaches, and it works really awesome. And it's not hard to do. I mean,
Right.
if you know the anatomy and know how to constitute this stuff, it's like not.
It's easier than IA.
Yeah.
Right.
Yeah.
It's every day.
Yeah, you got these RNs, monkeys that haven't hardly any training from do this stuff.
Yeah.
Stay out of the certain vessels.
Yeah, my wife already pays for it anyway, so.
Yeah, and don't put dermal fillers anywhere
Right.
there. Dermal fillers
Try and
belong
hold that,
there.
yeah.
Stay around, that's bad. That's dead. You make someone blind. Botox is fairly harmless, even if you got it in a vessel. I've never really seen a big problem with it. Anyways, so I would have the discussion with this person if the aesthetics Anyways, this was my accountant's wife. She lived in Virginia, and we started her treatment plan. We never finished it. Because he came back on his next trip, and I said, well, where's your wife? Well, there's a problem. Really, what's the problem? Well, when I got back from my last trip, I got home and caught her in bed with another man. So she's not my wife anymore. So I never got to treat this. So I kind of hope she's still walking around like this because she deserves it. But I don't know all the details. But what do we do about a situation like this? If the patient said, hey, aesthetics is my highest priority in this case, and I want it to look as pretty as it can, in my hands, that implant's getting buried, and it's getting soft tissue graft, and she's getting a bridge, some type of bridge. Because I can predictably create a pontic bed here and make the bridge way more predictably aesthetic than I can trying to deal with that implant that's way too deep.
Is there any way to make a crown that has like
Pink porcelain.
pink porcelain gingiva
Yeah.
contour up on top or something?
Yeah, that's an option. So if the patient said, hey, conservatism is the most, and I don't want to touch any other teeth, you could do a bonded Maryland style type bonded bridge, like a link bridge. But if the patient wanted to keep the implant, pink porcelain could be an option. The challenge there is, again, matching the pink and matching it in different light sources. It's not an easy thing to do, and the technicians that do it will tell you it's a hard thing to pull.
Those are gummy
I've
smile.
never seen them look really good.
Yeah,
I don't like them.
especially on one tooth like that.
Does her gummy smile bother her?
I wish I could remember the answer. I think it did, that's why she's
Would
in
a
my
full
office.
mouth
Got her to that.
crown lengthening, full mouth crown lengthening maybe in
That someone did.
surrounding area?
I think, the reason I don't think that's a good solution is because the teeth are gonna be proportionally too long.
They will be, yeah.
Yeah, too long. Crown lengthening wouldn't be an option. But we're gonna get into lips and evaluating lips, because you look at that and go, why is there gummy smile, and what are the solutions for gummy smiles? Because there's a very systematic way to evaluate, and the solution for it very much depends on what the cause of it is. Okay, so again, tooth position. So the key to treating dental aesthetics is knowing how to properly correct these 5 areas, okay? So if there's a tooth position problem, how do you correct it? Do you correct it orthodontically? Do you correct it by extracting it? Do you correct it restoratively? So we're going to go through each of these areas and show examples of each of these and how things are corrected. But first we need to know, how do we assess, Jared, this was kind of your question, is how do we assess the lips and the teeth in the face, and knowing how the teeth play into that, okay? So we evaluate the maxillary central incisors in relationship to the edge of the face, right? So we got this to the edge of the face. So we're looking at this incisal edge and how it lines up.